I'm Alice Finari. Welcome to the May 2024 Journal Club. And I really am excited because I have a great outside speaker for you today who's the author of the article, is on the author line of the article, actually the senior author of this article. And I always love when we present Journal Club um, as a author presented article versus another person interpreting it, I should say. So let me just get my view right because I want all of you. So thank you. So I'm really excited to have the author, a senior author of this article. I'm also very excited because we're taking a summer break from Journal Club. So I'm very, very excited. I take off June, July, and August, so we won't be back till September. And it's been a great year. I've had a lot of authors of articles come this year. So that really pleases me to be able to do that. And if you ever have an article you want to recommend, if you want to present an article, please contact me because I'll be filling up the next year. Okay, so to get started, I just wanted to share with you, this is an article that was published, and I just want to share my screen a minute, but let me get the article. I'm not sure I have the article here. I have the survey. Give me 1 second. So, Sylvia, why don't you introduce yourself while I just get the article up? How about that?
Sure. Hi, my name's Sylvia Botros-Brey, and I am a urogynecologist, and I was trained on the OB-GYN side, those of you that know about that specialty, but I'm actually practicing in a urology department currently. I also have some time in our Department of Medical Education, and I'm recently, in the past year, appointed as an assistant dean um, for faculty. But so these kind of professionalism things have kind of crept up in my whole career, first as a program director, then as an interest of study, and then now I think more so in this new role.
Great. And I see Nag Gabor here, who is an OB colleague. So I really appreciate that. Thanks, Nag. I thought this might be of interest to you, and you're a program director as well. So this is the article, just so you see it. If you all got this on attachment, Forum Theater to address peer-to-peer mistreatment in general surgery residency. But I think Sylvia will point out quite nicely how this is applicable to any residency, even though her research area was in general surgery in Texas. So certainly feel free to think about other ways to apply this and ask questions, which we'll have time for. I also sent you an additional article just to tell you that. And it was published in Clinical Teacher. And it is not her article, but it is certainly an interesting article that I just want to show you because it deals with mistreatment and using I'll put it in the chat. I'm not going to share my screen actually for this. I'm not going to share my screen. I'll put the other article in the chat. It's not Sylvia's article, but I sent it to her because it was using Forum Theater, which is Sylvia's technique of doing the work and dealing with microaggressions. We talk a lot about microaggressions in all our programs. So it's another article. You receive both articles if you registered for the seminar, so the Journal Club. So you have both of those, and we can, of course, discuss this with me if this is something you wanted to think about putting into your training program as an educational activity. And once again, it fits the need of things being interactive and alive and not putting up PowerPoint slides with bullets about, professionalism and what we should do right. So I really think this is a great way to teach. And if you get comfortable with it, you might use it more often. So I'm going to let Sylvia take over with her slide deck and talk about this. But the first question I'm going to ask before we get started, so you could share your screen, Sylvia, is can anybody share any of the challenges they're having with professionalism in professionalism issues in your program? any challenges that anybody would like to share? Be brave.
Yeah, sure.
Great. I invited you for a reason, Nag. Thank you. Nag is the OBGYN program director and a dear, dear friend of mine.
That's correct. And I don't believe it when you take the summer off hours, but that's a different story. Um,
No, just the summer off from Journal Club.
um, Recently, I'll tell you something that happened actually last week. Um, and I'm already dealing with it. I haven't resolved it yet, but um, one of our trainees made a mistake, let's say in the operating room, caused a perforation during a DNC, which she felt terrible about, which to me, I mean, she's a trainee, that things are going to happen. But the result was that the attending did not talk to her about it for the case. So there's no learning points from the attending. The attending, from this is from the resident side, the attending was totally mad at her. And the resident now feels that she's going to be, quote unquote, in the doghouse for the rest of the rotation. And she's not afraid that if she spoke to the attending, she won't be able to do anything. Uh, you know, and as a result, doesn't really want to scope with the attending. And although a week has passed, I was away last week. Although a week has passed, the attending still has not talked to her about the case. Although a fellow did talk to her about the case, but the fellow wasn't even present there. So I'm not sure why the attending is avoiding discussing the case with her. And I'm going to talk to the attending soon. When I was thinking about bringing them both together in the same room, I don't know if that's a good idea or not. But I don't know why the attending is mad. I mean, she's the buck stops with her, and the resident's not a trainee, and then things happen. You know, complications happen. It's just name of the game. You know, if you don't get complications of the surgeon, that means you're not operating enough. You know, it just happens statistically. So, and she's one of the harder-headed attendings. And once she doesn't like you, she doesn't like you, unfortunately. And that's an experience that many of the residents have experienced. And I'm not sure if I can change her personality. I know Alice talked about this morning, culture change, but when she said that this morning, I agree with her wholeheartedly. But this attending, I don't know, she needs a personality change to some degree. That's the problem right now.
So this is an example of a resident that the attending was more unprofessional than the resident, and that's role modeling, which is a whole issue in itself. And that's really, really important because the residents learn from the attendings.
Right.
So,
It's also an issue of like questionable retaliation. Not
right,
retaliation in the sense that she's going to get her, but retaliation in the sense that she won't let her do anything in the operating room going forward.
right, right. That her training will be limited. Anybody else have any issue? Ethan, have you had any professionalism issues? I'm calling you out of time wise with trainees. I'm calling people I know, Sylvia. I'm able to do that.
Yes, of course. You know, it works on both sides of the coin. I have faculty that in an attempt to stimulate residents to behave differently, you know, will sometimes use language which is probably not the best choice of words, and instead winds up, you know, scaring them. And then I have trainees who, you know, don't seem to understand the importance of you know, common professional behaviors like coming in on time. So, you know, it works on both sides, and it's a challenge.
Right. And I really think it's a topic that people really have hard time addressing. I had unprofessional behavior from an upcoming chief resident on Friday in the chief's course where Ethan teaches. It wasn't during his session. It was actually during an OSTE, which was an objective structured teaching encounter, and the standardized learner reported the resident.
Mm.
And that was fascinating because she noticed the unprofessional behavior. You know, it was on video cameras. They were working on Zoom. And then I'm speaking to the program director about that resident. So this happens in all settings, I want to say. So I am just want to say that this is a very important topic. I said for 2 hours in GMEC this morning, I can't tell you how many times I should have counted the word professionalism came up. Nag, if you were there, you heard it a lot today. It was just incessant, you know.
It
Really,
was incessant, and I'm glad you reminded me about the course today because I immediately went and signed up because I had meant to sign up, but I forgot.
right. Thanks. Okay. So I'm going to let Sylvia go on and talk about her system that she's created. What brought her there? She's a surgeon by profession. She, you know, obviously is an OBGYN surgical subspecialty, but what brought her to Forum Theater is to me so interesting also. So go ahead, Sylvia. You're on.
Okay. Thank you guys for sharing your reflections. And I do feel like these issues are really difficult and challenging. And whether it's the faculty, whether it's the residents, I think a word that was used today that's really hard but really important is culture. And hopefully I'll give you guys some food for thought on how to maybe start approaching these topics in a way that's effective. Because what I'm hearing, and I think my own experience has been, you know, someone does something, they're a bad actor. You don't really necessarily know exactly what to do with it or have the skills. You don't necessarily dig deeper. I mean, you can kind of think, well, this may be that, but you're busy. And so you pull the person aside, or you don't because you don't exactly know what they're going to say. You don't know how they're going to react. Um, you know, maybe you say, please don't do that again. Maybe you go as far as saying, you know, this is how it affects everybody. But those conversations are really difficult. I don't think um, I personally wasn't trained in how to deal with them. I think that's why the microaggression work is so important because it's something that's fairly new to a lot of us, and there's like skill development in that. And so I think if we take that idea of skill development, it might make this a little less challenging, and it might help us depersonalize because a lot of times this stuff feels personal when you have to talk to somebody about how they're acting. And I think there's a paradigm with professionalism that you either are or you're not. And so when someone's acting professionally and doing what they need to do, great. But when they're not, there's so much behind that. And so is there a way that we can come up with systems to think about it the same way we think about other competencies? Like you would correct someone for medical knowledge, right? But there's such an overlay with professionalism. So for this, the purposes of today, I was going to just hopefully have you walk away with this ability to maybe describe this process for how to use forum theater, consider the benefits of using it for professionalism issues, and maybe think about some of the barriers to its use, because I don't, you know, it may or may not be reproducible elsewhere. And Alice, just to clarify, I've actually used it for the topic of mistreatment in several different specialties, not just general surgery.
Okay.
Surgery that got published. I piloted it in urology and OB. I've done some work in internal medicine. And so I have a couple other articles that I'm happy to share with you guys if you want. But I had this tool. Let me just start with Forum Theater. And the clinical teacher article that you shared with me was from University of Rochester. And I have to say, before I ever really got into it, people at like AAMC, people on MedEd have been telling me about University of Rochester. So I think they've been doing it and incorporating it for a long time, but their publications have been more recent. So I don't want to claim that I'm like the first or the only, but I think I'm using this modality and targeting it to a topic, professionalism, and then focusing further in on mistreatment. So can I just ask you guys for a minute, when you hear the word mistreatment, what emotions does it evoke in you? And feel free to just call things out or put them in the chat.
It's a collection of frustration, disappointment, maybe a little bit of anger, but mostly it's the like, we're still doing this kind of cluster of thoughts.
Like, where are we today? Why are we still talking about this right now?
How did you think that was still or ever a good idea? Yeah.
Right. Any other thoughts, reflections?
and I don't know if this is pertinent, but the Knicks are in a playoff game right now, and basketball is going on, and I reflected how the culture of sports is so different than the culture of medicine. In some respects, the athletes expect to get mistreated if they don't do it well. You know, the St. John's basketball team coach in public called out his team, and he said they weren't very good in public to the newspapers. So, and I was wondering why that dichotomy is. I didn't come up with an answer. I mean, there are easy ways to say that. I mean, think about it, but I just found it interesting in my own brain that how we feel like mistreatment is. It is terrible, but in sports, it's almost accepted to a certain degree.
Yeah, thank you for that. As I've been trying to do this work, I've found that the word mistreatment itself is off-putting. And so I've tried to think of other words to kind of get people engaged. And I think professionalism might be the better word, and mistreatment is just a subset of that. But yeah, it's interesting what people tolerate, what people don't. And I think in our world, surgery and OB-GYN are the two that are most notorious for this word mistreatment. But let's not, it's not only general surgery and OB-GYN. All the literature states that 40% of learners have felt or have witnessed mistreatment. And you guys, that number, 40%, like you said, why are we still talking about this? Since the double AMC has been doing that GQ survey, I think back to 2003, even further back, like that number has stayed steady. So like no matter what we've done, no matter what we've tried to change, like this perception of mistreatment is still there. And if you look at the literature, whether it's pediatrics, internal medicine, general surgery, OB, that number is pretty steady, even in the GME world, although it's less studied. So just to give you some background, the double AMC has defined it, although I find the definition difficult. It's the intentional or unintentional behavior showing disrespect for the dignity of others, which unreasonably interferes with the learning process. So, okay, that's a definition, but I struggled with how do you operationalize this? And one of my colleagues asked me, well, what do residents perceive? Like, what do learners themselves perceive as mistreatment? And I looked in the literature, and there's lots of surveys. And it talks about the really aggressive and egregious things, bullying, harassment, sexual favors, these sorts of things, which those things I think are happening less and less. And there's fewer qualitative studies. But there was one article that was really informative for me where they talked about this incident-based versus environment-based. And I think environment-based is what we're getting at, that it's just in the culture. And if you think about maybe the idea of microaggressions, except not targeted like to individuals who are marginalized, but just in general, microaggressions that happen every day. These like small things that happen that you're not really sure, is it mistreatment, is it not? In general surgery, the New England Journal article had just come out about residents' perceptions. They surveyed all of the residents with their national standard test. And what was really interesting in that article was they couldn't find anything predictive. It wasn't general surgery. It wasn't academic. It wasn't community. And what they concluded, and have further articles to say, is that it's sociocultural. So that it's really contextual, right? So we're back to that word again. So in our, so when we started looking at general surgery residents, we thought, okay, how do we approach this? What can we do? And here's just, one statistic: 18% of surgery residents reported bullying from surgeons. And bullying is kind of the word that we'll use as the thing that bubbled to the surface in this study. And I was really focused on the residents as learners and how they treat each other. If you think, once you hear about this form theater a little bit more, I don't think it was going to be safe to get residents and faculty to debrief on this, right? So where could we start? And so I thought, well, what if we just do it in a peer setting? That might be a little bit easier to tackle. And so hence the peer-to-peer mistreatment. So just to kind of summarize these considerations, things that were making me like, why do I even want to study mistreatment? It's difficult to define and identify, which makes it hard to address, right? Like if we don't even really know what we're targeting, how do we address it? This number 40%, pretty ubiquitous, spanning all different fields. And it really struck me that learners are in the center, right? So our residents, they are either receiving it, whether that's faculty, patients, nurses, peers, but then they're also in a position to be perpetrators, right? That they can then mistreat each other, they can mistreat students, right? And so it's a really formative time. If we can get them as they're training, maybe we can break the cycle, or maybe we can raise awareness in a way. And so how could we do that? Like what, could this tool help us? So our objective of this study was to see, we'd already piloted it in OB-GYN and urology, but we wanted to see if form theater was acceptable, and could we address mistreatment in general surgery, like really fast-paced situations. Okay, so let me just pause for reflections. Dr. Fernari really wanted me to kind of stop and get your impressions as we go along. So just what are your thoughts collectively about like mistreatment as a topic? And then how many of you have heard of form theater?
How many people? Let's start with the really concrete question. Form theater, is this like new to everybody? We want to get like the temperature in the room.
I never heard of it.
Okay, thank
Same
you.
here.
Totally new.
I already like you, Gary, because you participate as a program director. Thank you. Totally new. So we have a lot of fresh people, which is what I told Sylvia, but I'm just trying to verify it. New. Everybody's new. Okay. We really have to concretize this.
Sure. Okay. And then what are your thoughts about mistreatment as a topic?
It's essential.
It's never ending and ongoing and a forever topic, I think.
Okay. All right. So forum theater was developed by a Brazilian playwright named Augusto Boal. And he used it. It's actually originally called Theater of the Oppressed. And when I started in on this work, one of my colleagues was really opposed to me using the word. And I think there's something to words, right? And so just like mistreatment is one of those tough words, he was like, please don't use the word oppression in medicine. But his idea was that if you come in as an outsider into a system where people feel oppressed and give them the solution, it may not work. It may backfire on you. He had that personal experience where it actually backfired on him and then people didn't trust him. And so he thought, well, what if we go in and we get the stories from the people? Like, what is the thing that's oppressing them collectively as a group? And can we encourage them or empower them to come up with solutions so that they're the ones that are going to solve the problem, as opposed to an outsider coming in and saying, this is the solution. So that's just kind of like the broad kind of high level thinking about it. And he did this using theater. And so it's a very interactive form of theater where you pose a scenario and the scenario is very relevant to the group that you're working with because it's their stories. And it's anonymized so that the story feels relevant to the majority of the group. And then you present the scenario, but you present it in such a way that it's not solved. Like it actually ends on a really uncomfortable note. It shows the oppression, and then that's it. It's almost like the idea of a trigger video, if you will. So we're going to present you with the scenario, and then that's it. We're not going to give you the solution. And so you debrief on the scenario, you talk about it, and then you start talking about what are possible solutions? What would you do in this situation? What would you do in that situation? And initially, he'd have the audience members suggest to the actors what they would do. And then the actors would act out the solutions. And what was really interesting about this is as you're acting it out, sometimes the action works, and then great, you could see how that works or how someone would do that. Sometimes the action actually didn't work and backfired. And then you could also debrief on why it didn't work. And so the group collectively gets to problem solve until there's a solution that works for them in their context. And so that's what the spect actors are. So they're watching, they're spectators, but they actually become actors. So at some point, they're not just offering solutions for the actors to act. They, once people get comfortable, they eventually get invited in to act out their solution. Does anyone have questions about kind of the format of what it is?
So you actually use actors to act out a real authentic scenario, right?
Yeah, although my actors were resident volunteers. So I went into general surgery, and I had a couple of residents, that either volunteered or were voluntold, but their time was protected. And they helped create the scenario and they were the actors. Yes.
Right.
They wrote the scenario.
Sorry?
You're a little muffled. You're a little muffled.
Yeah, I forgot
Okay.
my microphone.
That's okay.
They wrote the scenario themselves.
It was guided, right? So I had to go in and get the stories, and then I presented to them. Here are kind of some scenarios that are repetitive. I feel like this might be something to think about, and then they would say, actually, yes, that of course that's the thing, and then they would give me the context for how it played out. Does that make sense? So after we did the focus groups, because I had to get their stories somehow. So I actually tried to get focus. I did focus groups with them. And then I said, okay, here's what's coming up. And I maybe offered one or two things. And they're like, that's the thing. And it can tell you exactly how it happens. And then we would create the scenario.
So just to make it concrete, as Alice said before, taking my situation, we would just act out or pretend like something bad happened in the OR, and that's end scene.
Yeah.
And then the question you pose as facilitator is, what do you think happened next? Or is the question, what do you think should happen next?
Yeah, so you could say something bad happens in the OR, and you could even go as far as having the attending walk out. You could have the attending yell. You could, whatever it is you want to portray. And then I usually start with how does this make you feel? Right? Because sometimes we have to get out of our logical brain. How does this make you feel? Is this relevant to you? And so far, this was awful. This was frustrating. I feel, bad for so-and-so XYZ. And then they'll say, this happens every day. Like if you get the story right, the majority of the group says, yeah, actually, I've had that experience too.
Right. So it's an authentic story is very, very important. I'm getting the sense.
Yes, it has to be authentic. And I'll tell you, I can show you we created videos for OB-GYN. When I showed my OB-GYN video to my general surgeon, he just kind of laughed and was like, what's the problem? But when I showed that video to my internal medicine colleagues, they're like aghast, right? So it's very, very contextual. All right, we'll keep moving. Okay, so to concretize it for general surgery, and we'll come back to this, but they wanted to address what they perceived as bullying in the form of feedback. And so the story goes that a resident team will be on call overnight. And in our particular scenario, the on-call resident was asked to order a CT scan, but forgot to do so. So checked out to the oncoming team and then went home. When the intern presented to the team that the CT scan wasn't ordered by the night team, but they had finally put the order in, the chief resident said that's unacceptable, proceeded to call the intern that was at home, presumably bed and sleeping, and then ask her in front of the whole team why they didn't get the CT scan and how unacceptable that was. So let me just pause and let you think about that for a second. I was really surprised and shocked to hear that. I don't know if you all are shocked to hear that, but that was the ubiquitous story. Yeah, I'm nodding. Okay. So when I brought the residents together, the small group, we explored why it was distressing and what was going on, what was underlying that. And so part of forum theater, there's several different parts. And one of the things you can do is something called image theater to give you a sense of the emotion that goes with this. And so this, I don't know if you see this resident who's laying on the floor. This is a real life resident. This was supposed to depict her post-call. And she's checking her phone because she can't sleep because she knows the call's coming, right? So here they are. They might be violating duty hours. They might not. They're supposed to go home and that's supposed to be your time of rest, but they can't fully sleep because they know something's coming. And so it not only affects their morale, at the time, but now like in their home life when they should be resting. So that's what came out with this like picture. Like I'm post call, I really want to sleep, but now I got to answer or be on this call. So then we were like, well, what would good look like, right? Well, good would look like that maybe I could sleep. And so that's the middle video. And so we envisioned that. But if you notice in this middle video, the phone is still next to her, right? And we were like, well, what would even better be? Even better would be like if I could just go home and go to sleep and not even worry about my phone, which is the third video. So these are just like some of the tools that we have with forum theater to like express like, because I don't have a full video to show you the entire forum that we did, but here's just like the crux of why that behavior was so distressing to them. Any thoughts, questions before I move on?
Yeah, I just raised my hand. So when you do all this, I imagine in this group of residents, they probably know which chief resident did that, let's say. How does it help correct the chief resident's behavior if they're not there, or if they are there?
Okay, so we'll move on. There's more to this story. And the reason this story was chosen, it wasn't one resident that was doing it. This was kind of their collective behavior. Like this was accepted behavior on the surgical in the surgical residency. And so I would say that's a good point. You don't want to do something that's going to call any one person out. You want a story that's going to get at the culture of the place. The things that they can't see themselves that you want to bring to light, that talking's not going to work for. Okay. So I had to do some prep work. What is forum theater? How do I even implement it? And so I went to New York. I had a mentor here that was really adamant that I use this modality. She loved it and really wanted to see someone here use it. And I was like, what would I use it for? What would I use it for? And once I found my topic as mistreatment, I thought, okay, this could be a good tool for it. There is in New York, the Theater of the Oppressed New York, where you can go and do week-long sessions to learn how to do forum theater. Like they're totally artists. They put on plays all the time. And I think at the time, like I paid $500 and then whatever my flight was to New York and like my hotel. Best money like I ever spent. I learned so much. And it just so happened that I have a person here at a like local institution that is an expert in forum theater and had worked with our team before. So he mentored me, like, as I was trying to like take what I learned from the arts and morph it into like medicine and health professions. He helped me with the first couple that I did. So I piloted it in OB and urology, just like, is this even feasible? Can we do it? Found my topic and then needed to get buy-in and stakeholder support. So at this point, I knew the surgery program director. He had to get buy-in from the wellness committee. We had to get protected time for the residents and the volunteers. And then we had to have didactic time so we could actually do this. So that's kind of the time commitment. We took an hour where we did our focus groups, and then we did like 3 months later, another hour where we actually played the scenario and had the forum.
So I just want to say that we might have an expert at Hofstra University because there is an entire theater department if people are interested in this.
Mhm.
We do have a partner university, so it's just something to keep in mind.
Um, so then I was like, okay, how do I take this like theater process and translate it into medical education? And so the way that I did it was I got to get the stories. And then I thought, well, can I do more with the stories? What if I turned it into qualitative research? Because we don't really have a lot in the way of like learners' perceptions of mistreatment and what mistreatment is. And so we actually did semi-structured interviews focused on like what are your experiences of mistreatment, and we asked them kind of broadly and then asked them to kind of focus in on that peer-to-peer piece. And then I like listened to the stories and came up with like this, here are some things that could be a scenario. But then I had another team that actually did the qualitative evaluation. And that is like a sister article that's published if you're wanting to know like their experience of mistreatment. Forum theater was my tool. To me, it was like role play, but on steroids. I was sharing with Alice. I don't know how many of you have been in like a situation where you're given a role play scenario. It's not necessarily really well described what you're supposed to do, and you're looking at your partner and you're like, what am I supposed to do? Am I done? Am I not? And so I've just I think that it can be done really well, but my experience in role plays hasn't always been that great. And so I thought, well, maybe here's a way that like we could use theater, but instead of like people independently trying to figure out what we could do, we could use the power of the group. And that's what I found. And then how do I even evaluate this? How do I get it culture? How do I get it like, how could I convince someone that this is worthwhile? Just that, I've got this great innovation, but how can I show you the data that it's worthwhile? So I looked to see what was already out there. And the people at University of Chicago and North Shore had done some videos on professionalism and had a survey that kind of got at some of this. And so we modified their survey and used that as our evaluation. We did a pre-post and then a 6-month post afterwards. So these are just kind of like phase 1 is our focus groups. Phase 2 is you've got to get your theme and then develop your scenario. And then phase 3 is actually the like implementation of the forum theater. So that's where your actors know the scene. They've rehearsed it several times. You prep them that they're going to do a bit of improv. You present it to the group, and then you have a facilitator that's like moderating what people are saying, who's coming into the scene, who's not. That's the training, like, is just how to even run a theater like this. So phase 1, here's our focus groups. If that other paper has more detail, but we had those questionnaires. And this was like, it was kind of like early COVID. And so we were learning that we could use Zoom for the, recording and transcribing. And I had several people that could run the interviews. And so we took that 1 hour and we had like 4 breakouts. We had our interns in one room, our second years in another, third years, and then fourth and fifth years to get like the data all in one shot. I think I'm kind of belaboring this point. Phase 2 was our scene development, and then phase 3 was that forum theater during that didactic wellness.
And it was 1 hour. It was 1 hour.
We did it in 1 hour. Yeah.
So that's
yeah. And then the survey was based on that study by Didwania. We did that retrospective pre-post, and which was done immediately after the session. We had paper and pen, and we're like, here, fill this out before you go. And then we graduated to QR codes and REDCap. And then we did the 6-month post survey, which was on REDCap. And I think, Alice, you have those questions.
I put the survey in the chat. I put it there for you so you could see it. It's in the chat. I promise you. Forum theater post. It's there in the chat. I put it at 12:17, so you should be able to see it.
Perfect. And it's an addendum in the paper, but there it is for if you guys want. So let's just stop for a minute. What are your thoughts on that methodology? Like taking something from the humanities and trying to like translate it to medical education, health professions.
You have to have the right crowd.
Tell me more.
Um, I mean, I'm sure that there are some trainees that will respond to it, and there are others that will think that it's not, they won't come at it with the right spirit.
So,
Yes.
Ethan, this is like, I think it's a great description, role play on steroids. We do a lot of role plays at the medical school, a lot, but it's not as common in residency, right? People,
When it is, it's perfunctory. It's performative. They don't. It's not a real role play. They just sort of. It's hard to describe, but it's the in the medical school setting, the students seem to just take it more seriously and actually want to hit the uh, hit the points that they're supposed to hit. Whereas when I do role play with my residents, very often it's not approached in the same spirit. It's not taken as seriously.
Yeah, I've had a similar experience to Ethan, but not at my program because my residents haven't started yet, but at other places when I go around. And so I ended up using videos that were really like careful to select the OB specific video that works versus the anesthesia one, which is really similar, but it's not. And getting them to engage in that like third party thing sounds like a surrogate lesser version of this. But the interactive nature and being able to actually adapt and get solutions from processing to it sounds great if you can just set it up so it works. Which I'm excited to see how we do that.
Yeah, I appreciate your comments. And one thing that's probably I left out that seems so intuitive to me, but it's worth mentioning. When we did the focus groups, the program leadership was not included. And we told them that we weren't going to share direct stories with their leadership. So we tried our best to create psychological safety. And when we ran the forum, I was the only faculty in the room. And each group, each time I've done it, I've asked, do you want your faculty or not? And some groups want like the urology group, super open, wanted their faculty. General surgery and OB did not want their faculty. So when we do these role plays, there's a couple things that I think bring what you're saying to bear. Like it's a whole program and the leadership is involved. It's not me just coming in and going, hey, we're going to do this thing, right? Their leadership says, we're going to do this. We're going to do this for your wellness. We know there's an issue. Usually there's an ACGME survey problem. Like, so the whole program is invested in trying to figure it out. We try to establish that safety. These are the stories that they've given us. And when we do the role play, I am the only one in the room with them. Running the facilitation. To your point about the videos, that's like my next project is creating videos that are specific to each department. And maybe Forum Theater is like that deep dive or like, people that want to take it on, or maybe this could be a consulting thing, but I think the videos is probably a slightly safer way to go. The whole point is to generate discussion about something that is not so easy for you to just say, stop doing that, right? Like, how do you like mirror back to a group? This is what your culture is. What do you think about that? Let's be intentional for a minute. Do you want to continue? Or if not, how can we change, right? And those are the discussions that need to be had. And that's where I think theater can help us do it in that third party way that's not singling out any individual, but it's looking at the group collectively, because the group collectively has a personality, which is called culture, right? Okay, so let's move on. So here's our results. So we got the phenomenological data, and just really quickly, what I found in that general surgery grouping is that there were 3 big things that came out. Psychological safety, presence or absence, is really important. Hierarchy, is that hierarchy functional or dysfunctional? And teams, how do the teams function? And so I think that if you're wanting to think about like, how do we even address this? Those are some things you can start to look at, because if there's not psychological safety, people aren't going to be able to own their mistakes. Things are going to be taken personally. you're going to have like this what was going on in surgery was this perfectionism culture. Nobody could make a mistake. Mistakes weren't allowed. So the residents, instead of taking the time to teach, would just kind of huff and puff and move on because they had to be answerable to someone above them. And I don't think the faculty realized this was what was going on. Often what's going on in the residency group is like has its own life, and the faculty don't realize that the things that they're doing or saying are promoting like this culture. And I don't know if that sounds shocking to you all, or if that's like, oh yeah, that makes sense. But that to me, like in every group that I found, the residents have this perception of the way things should be or need to be. And it kind of takes a life on its own. And when you talk to the faculty like, I would never want that for my residents. And they don't realize that this stage or modeling that they're doing is in fact either contributing or not. Yeah, please.
So after this, where you said it was basically the residents plus or minus faculty, um, a lot of the times I think the problems are residents versus faculty, which you were just describing. How do you change your faculty if they're not really buying into things?
Well, in this case, I think that's a harder question, right? But there's a couple of, and Alice, you can help here, right? There's a couple of strategies for faculty, right? I think if you go in guns blaring, you guys are the problem, no one's going to respond to you, right? But sometimes if you engage them to teach something and then teach them, it's kind of a backhanded way to get your faculty to learn something you want them to learn. So we did a lot of, what we did personally in general surgery was we presented the data. This is what's going on in your residency, right? And this is what we're doing with the residents. And here are some things that maybe you guys you can consider. Our program director felt like feedback, which it sounds like the faculty you were talking about early on, just making sure that everybody like knows how to give feedback, keep things not personal, stick to behaviors, right? If you can get feedback right, you can mitigate a lot of this stuff, because a lot of times faculty get frustrated and they don't know what to do, so they walk away, they personalize things, they make generalized statements. And so in our general surgery qualitative data, they felt demeaned, dismissed, and diminished, and that they understand they need to get feedback, but it became mistreatment when they started feeling those things. And one of the things that was really surprising to me was like being persistent. So we talked about the 3Ds and the 3Ps. Don't make it public, don't make it personal, and don't be persistent. Sometimes they don't give you the satisfaction of saying, oh, that was really great feedback, thank you. They might walk away, or it might happen again, and then you feel like you need to say it again. So the things that we took back to the general surgery faculty were like, your feedback is really important. They know they need feedback. Just don't make it personal. If you have something corrective, don't be public about it, and try not to be persistent. And then they did a whole faculty development around that. And then the program director decided to do retreats. They're changing their ACGME. They're wanting to get their ACGME surveys better. And then they found that there was like a deeper issue and brought us back in to go. It's like peeling the layers on an onion. And now I can say that there's a lot of turnaround and growth, but like this work is not easy. And I wish I had a quick solution for you, but I'm also learning that mistreatment is the tip of the iceberg. And it's very rarely this person versus that. And a lot of it is systems that are built, and like thinking about how can you in small ways change structures, and make that psychological safety so people can talk about their mistakes, give people the skills and tools to be able to give feedback. I get really passionate about this, so I think I'm rambling on a little bit here, but did I answer your question?
Yeah, it's just maybe I'm looking for a quick fix, but you're right. It's a long uphill.
We talked about psychological safety to this morning also. This is not a quick fix. Definitely not. I just want her to get through the rest of her results, so just continue because we're tight.
Okay. So the residents in that scenario realized that they don't necessarily need to call. They can maybe just pull the resident aside before they go home or when they come back on shift the next day. But that practice probably needs to stop. And so here are results from that survey. We actually found from like the immediate post, pre-post, and the 6-month post, their understanding of what mistreatment was increased. Their confidence in the recognition of mistreatment increased. Their actually their confidence and ability to intervene when they witnessed it increased. And then recognition when they themselves were involved in mistreatment increased. And so here's just the forum theater effectiveness. The majority of participants felt that it was quite or extremely effective, and 89% most likely or definitely, yes, would recommend forum theater.
That's very good.
Yeah, and this was sustained over the 6 months. Here are just some like of the qualitative comments that they enjoyed this. They liked that it was active participation. They thought there was great discussion, resulted in thought-provoking discussions. There was one, there's always going to be one or two that just don't like theater, don't want to get out, don't want to be. But the nice thing about this forum is not everyone has to participate. You can also have that like learning where people are just watching. And then the ones that want to jump in, it gives them an opportunity to jump in. I think we're almost done. So, I mean, our takeaways was that it can be tailored to your local culture. It was effective in our diverse residency, and it did seem to offer sustainable benefits. Some barriers are that there is a special expertise that's needed. You have to have pretty good facilitative skills, and you kind of think on your feet. So this isn't scripted. A lot of this is like, because they're giving you the solutions, and so you have to be able to work with them. And it is a time commitment for sure. So these are some reflections I had. We have to think about culture. The residents in surgery thought about bullying, but I think mistreatment, I think someone in the chat noted that people perceive it differently, and amongst the different groups, people perceive mistreatment differently. This allows for group problem solving. It's a way to raise awareness regarding an issue that affects your whole team, not just one person, and it gives them a safe space to discuss the issue. So while we're problem solving, they're also, struggling with themselves about the reasons why they're doing it. And so a lot more comes to light than just, oh, we got to stop this behavior. You know what I mean? Well, we're doing it because, and then you can say, well, but why is that the case? Or is there another way that you think about that, right? And so you really are allowing them to, outside of the just day-to-day of like, we got to get this done, like just reflect on what are we doing. So that's it. Any thoughts, questions? I just
want to thank Kelly for her comment that we have an educational retreat, and maybe we should try this during the educational retreat, because the retreat is focused on professionalism. So maybe I could discuss with Dr. Yacht somehow having Sylvia come. I don't know. I have to think. And Ellie, you want to ask a question? Ellie's very involved in a subcommittee of professional at Staten Island. Did you want to say something, Ellie?
And Alice, we have some members today from that subcommittee just attending the Journal Club. Sylvia, thank you for the presentation. The question I have for you, have you ever thought of doing that forum theater where faculty will portray a case and faculty will be attending? Because I think, empathy, self-reflection, recognition, definition, buying in. And I think Amanda spoke about, generational the difference in definition of what's mistreatment. There are like lines you cannot cross, but there are these shades of gray in these definitions, which are like very important. Have you ever thought of like having faculty portray a case with an excellent facilitator and going and say, so what do you see? What happened? What was wrong here? How are we going to take it from there? I'm really interested in knowing your experience on that.
Yeah, thank you for asking. So again, my Office for Faculty role, I think that this modality and this topic like spans the continuum. And so I've done it with medical students and I have done it with faculty. We presented it at the Academy of Surgical Education, I can't remember what A it was, but their program directors conference where we did a forum theater for program directors, and that was pretty well attended. I presented at the ACGME. They have the competency course has a group of leaders that are distributed nationally. And so we did a forum theater with that group. And so, yes, want to continue to explore how to do this with faculty, because I think you're right. It's skill building and it's perspective taking. And this allows for that in a way that just lecturing doesn't.
So you're saying if we were able to bring you to Northwell, you'd come back and run a forum theater for us? Is that
I
what?
would love to. We're just absolutely.
Okay, Kelly, we're on it. Kelly, we're on it. Okay.
Yes.
Okay, Kelly's going to be my partner in crime, and we can have this at the GME retreat or it's the education retreat now. So maybe we could have that. Thank you, David, for coming. I think we have to close up, and I really want to thank Sylvia and thank everybody who supported Journal Club in the last academic year. I'm going to contact Hofstra and see if there is a forum theater expert at Hofstra, because maybe we could get some guidance from Hofstra University. There's always that push to partner with our partner.
For sure.
And I'll see about that. But Sylvia, I have a feeling we might be able to get you in real time with us up to New York.
That would be fantastic. And thank you very much for your time and listening to me. And hopefully I planted some seeds for you guys.
And I hope everybody on here reads both articles, and the survey that she used pre-post is in there as well. So in the chat, but you did receive the articles on email if you registered. So that's great. Any final words anybody feels they must say? Leanne, we didn't get to your bibliometric side, so I'm going to give you the last word. What do you think?
That's fine. Just so far, it looks like there have been a bunch of captures for your article on Mendeley, Sylvia, which is a reference manager, and it's kind of indicative that people are going to be going back and reading it and potentially using it in their own research. And since it kind of sounds like a program that takes a while to set up and run through, it's not very surprising there haven't really been any citations yet. Also, I'm going to put a link to the survey for the meeting in the chat too.
All right. And you will get the PowerPoint and the survey when I figure out how to, we'll share the PowerPoint. We had some trouble this morning. So yeah, so we always look at the bibliometrics, and I thank Leanne. And we didn't really, this article has not been in the social media world much, was it, Leanne?
No, it hasn't been.
Which is interesting. So then you have to learn to get your article in social media. And I do want to give a last word. Elizabeth, are you still here, or she had to leave? Elizabeth, are you here? Elizabeth Katcher is my partner in crime for a conference called the Association of Professionalism in Healthcare. And I'm involved in that conference program planning, and we will be in Philadelphia the first week of June, right before the academic day here. So if anybody wants to trek to Philadelphia, the whole conference is focused on professionalism. And that's how Sylvia did this work, through the LEAP Fellowship that Ellen Perlman and I did prior to her. So there's a whole world of people looking at professionalism. And I'm also editor of a new book that's going to be coming out on professionalism, if we get the chapters done, the process. And thank you all. Everybody have a great day.